So hello everyone, I am Andrea Gerwin. I am one of the pediatric clinical pharmacists here at the Children's Hospital. And today we're going to talk about cystic fibrosis, pharmacotherapy, and the expanding role of pharmacy services. Really, this is a lot like a CF potpourri of different pharmacology that we need to know as pharmacists. And then some of the more recent data about the impact pharmacists can have in CF clinics. I have no disclosures or conflicts of interest. And this is a quote from the Middle Ages, which I thought was really interesting, most likely describing a disease that was cystic fibrosis even at that time. Some of the learning objectives that we'll go through are reviewing the epidemiology, etiology, and pathophys. We'll describe the different genetic classes and functions of the mutations because that will tie into our pharmacotherapy at the end. We're going to talk about the resulting organ damage that patients experience, list the roles and targets of the supportive therapy we use, and distinguish reasons for altered pharmacokinetics. I know a lot of the adult pharmacists here may encounter CF patients during admissions, so kind of understanding why some of the medicines are dosed differently would be helpful. We're going to talk about the classes and the mechanism of the CFTR therapies, the correctors and potentiators. We're going to look at the long-term outcomes, which are really short-term outcomes at this point for the modulator therapies. And we're going to describe the monitoring and counseling points, as well as pharmacy intervention opportunities. We're going to use a patient case throughout this presentation to kind of reinforce some of the principles we're learning. So JL is an 11-year-old male with CF. His genotype is represented there, and we'll dive more into what genotypes mean. He presents to clinic today. It's a quarterly checkup. Patients are often seen 4 times a year, more often if they're sick. We draw the cultures, height, weight, and then pulmonary function testing. He reports no cough or shortness of breath today. So an FEV 1%, if you're unfamiliar, that's a forced expiratory volume in 1 second. This is usually measured in liters, but you need to compare those liters exhaled to what a standard would be for the age and gender of the patient. So we typically represent this number in the percent of what they should be. So if a normal FEV1 would be 100 to 110%, a depressed FEV1 would be 85%. So for his pulmonary function testing today, he had a measure of 85%, and his previous FEV1 was 91. His weight and height are recorded there. You can see his BMI is in the 5th percentile for his age and gender. His cultures today are pending, and his previous cultures were just mixed respiratory flora. So we'll use JL throughout our presentation to talk about some of the different therapies that we have. So the epidemiology of CF, it's predominant in Caucasians, 1 in 25 to 3,500 births. It exists also in African Americans and the Asian population. The life expectancy has changed over time. So in 1970, the average age of a CF patient would have been 18. In 2013, through different pharmacologic interventions, this has now been expanded to the 4th decade of life. In 2021, with the advent of the modulators, we're not sure how much life expectancy we've added to the population. So when we think about life expectancy, it's important to talk about therapy development. So in 1989, the cover of Science magazine was this little guy right here. His genetic makeup was used to identify where the mutation was for cystic fibrosis. And if you think about 1989, cellular biology at that time probably wasn't what it is today, but the human genome had not been mapped. So this was quite a feat that came from 3 different labs working independently with funds from the CF Foundation. And the CF Foundation used a lot of marketing strategies to raise funds for the research. And so this advertisement of this child who's 12 years old and now at middle age is one of the advertisements they had used. And it also speaks to the fact that the life expectancy has changed really because of this therapy development. And now we know that there's over 2,000 genetic variants of this mutation that they found, this gene. So for etiology, so 2,000 different variants. You can have 2 parents that are carriers of just one of those variants. And they do have a 25% chance of their child having the disease CF. It is an autosomal recessive, which is represented here by the carrier status. And then the genotype will express the patient's phenotype, so their disease CF. They could have 2 children that are carriers and then 1 child that has no copies of one of the 2,000 mutations. So when we look at mutation types, this will become important later when we start to talk about therapies. The normal chloride conductance in the CFTR channel is represented to the far left. And then it goes by genetic classes and the mutation types included. So class 1 has absent functional CFTR. Class 2 also has absent functional CFTR, but it's really because it got lost inside the cell. And we'll go through some videos that help reinforce that. Type 3 is a defective channel regulation. Type 4 is another type of a defective channel. And then 5 is a scarce functional. And then 6, we really don't talk about that much, but they have increased stability in their CFTR. And the first mutation that was discovered was a deletion at the position 508. And that was a deletion of phenylalanine. So that's how you get the PHE 508 del notation. That particular type of mutation is one of the most common ones. And we'll see that, we'll talk about drug therapy related to that. It's a class 2 mutation. Okay, so these videos worked before you guys got in here. Let's see if I can get them to work again. We may have to watch an advertisement. It's definitely not a sponsor. No, Google's not a sponsor of this presentation, but I had trouble skipping ads earlier.
There are upwards of 2,000 mutations in the CFTR gene associated with cystic fibrosis that fall within 5 classes. In class 1, production of CFTR stops early, resulting in no functional CFTR. In class 2, deformed CFTR folds improperly and gets trapped in the endoplasmic reticulum. In class 3, CFTR arrives at the apical membrane, but its ion channel cannot open properly to transport chloride. In class 4, CFTR arrives at the apical membrane, but its ion channel is misshaped and channel function is poor. In class 5, successful CFTR production is decreased, resulting in low levels of functional CFTR.
So that describes, again, the same information we just went over, but more in a visual manner. And then I'm going to use a video to sort of show you what the function of the CFTR is once it reaches the surface, cell surface.
In cystic fibrosis, this airway surface liquid layer becomes dehydrated, viscous, in a site of chronic infection because CFTR is either not present or not functioning correctly. In cystic fibrosis, CFTR is not able to conduct chloride into the airway lumen and does not provide normal regulation of ENaC, resulting in excessive sodium resorption from the airway and a dehydrated airway surface liquid layer.
Okay. So 2 videos that kind of tie together what are the mutation types and then what is the result of those mutation types. It focused primarily on the airway because that is the target of a lot of our pharmacotherapy, usually a reason for morbidity and mortality in CF patients. So we spend a lot of our time trying to improve their pulmonary function with our different therapies that we'll dive into later. So to the pathophysiology, you have a cross-section of an airway. So that shows again the thick secretions that cystic fibrosis patients would have within their airway, which creates the inflammatory environment where bacteria can also grow. In the liver, you can have thick bile, and that can also cause cirrhosis of the liver. And then within the pancreas, you can have clogging of the pancreatic duct. And this inhibits the release of your pancreatic enzymes. And then later in life, we can see that it can lead to diabetes. So clinical manifestations, the sinus and pulmonary disease are the respiratory manifestations. And like I just mentioned, those contribute significantly to morbidity and mortality. Patients have malabsorption because of their pancreatic insufficiency, and this is a majority of your cystic fibrosis patients. Insulin deficiency and tissue insensitivity occurs over time as patients get older. So it's really not type 1 or type 2, it's really type 1.5. So the management is slightly different, but 25% of patients by age 25 and half of patients by age 50 will have CF-related diabetes. And then it also has reproductive consequences, leading to infertility in both males and females. So back to our patient case. So during his visit, JL meets with you and you reconcile his medications. So this, I would say, is an average medication list for a CF patient. We will talk about albuterol, creon, azithromycin, lansoprazole, pulmozyme, the Dornase alpha, 7%. We'll touch on multivitamins, but there's a lot of those. And then ursodiol and how they affect each of their organ systems. So supportive pharmacotherapy comes in the form of your enzymes, vitamins, reflux medicines, constipation related medicines, and then your diabetes, your liver disease, which can be a result of those clogged ducts as well. Pulmonary, we have non-pharmacologic management, bronchodilators, mucolytics, anti-inflammatories, and antibiotics. And then finally, we have the CFTR modulators, which are a newer class of medications. So to start off with the enzymes, like I mentioned, most of these patients will have exocrine pancreatic insufficiency. One of the screening that we use for newborns is an immunoreactive trypsinogen, which is actually elevated in patients who have pancreatic blockages even as early as birth. So if that IRT test is positive in a newborn, then they will be referred for additional screening for cystic fibrosis. Lipase is the most efficient enzyme, and that leads to fat malabsorption, which can lead to malnutrition in these patients. So we call this Pert therapy, pancreatic enzyme replacement therapy. The dosing is based on the lipase component, so upwards of 2,500 units per kilo of lipase per meal. The brands are not interchangeable, and really they're not FDA approved to be interchangeable, but also the CF Foundation does not recommend changing a patient's enzymes once they've been stabilized on a certain formulation. The doses are titrated to the upper limit of the weight-based dose if patients have malodorous stools, abdominal distension and cramping, or if the children reach sort of a growth or a weight loss plateau. So there is a role of acid reduction for the Pert therapy. So inside the capsule of creon or any of your enzymes, it is enteric coated. So the idea is you want this to release in the small intestines, and usually the pH of the small intestine is higher. So we can use H2 antagonists, or PPIs, to help facilitate that change in pH and in the small intestines. So it can be added to increase the pH there, which these patients we believe have decreased pancreatic bicarbonate secretion anyway. So a lot of times this will be added, but not every patient is on it. The stomach pH and then the small intestine pH are vital for efficacy. And with adding an acid reduction agent such as an H2 or PPI, there's limited data for long-term survival, but we do believe it helps. A question that often comes up is, how do you get enzymes into babies? So you have this newborn screening, you have a patient who's positive for CF, they go through the additional testing. So how is that parent going to get enzymes into their 6-week-old? So we recommend baby foods with acidic pHs, and they have to actually open the enzyme capsules and sprinkle it onto the baby food, which is probably counterintuitive to every parent who's in here who doesn't get baby food before 4 or 6 months. But we will actually use small amounts of baby food to help get the enzymes into the patients. It has to be used immediately, and the microsphere should not be crushed. Vitamins. So this is another essential part of CF maintenance and care. The patients will have malabsorption of the fat in their diet, which leads to the vitamin deficiencies. We do know now that patients are living longer, so we're seeing more bone disease from chronic low vitamin D levels and increased fractures. So we monitor levels of vitamin A, D, E, and K annually, and then we target supplementation with a CF-specific vitamin. And usually these will have much higher amounts of the A, D, E, and K in them than your typical like over-the-counter Flintstones. There's a lot of different programs too where patients can actually get these vitamins free if they're taking certain enzyme products. For liver disease, the CFTR defect occurs also in the cholangiocytes. It can lead to bile duct obstruction, sludging bile, microgallbladder, and biliary cirrhosis over time. So these patients will often be on ursodiol if they have had any of these findings on ultrasound. Ursodiol will thin the biliary sludging and it prevents or slows the hepatic damage that occurs. So for the pulmonary system, we have some non-pharmacologic therapy. The first picture of the infant that's sort of laying upside down, this is chest percussive therapy that we will teach parents to do. So they position their baby and they will basically pound on their chest with a cupped hand to help loosen secretions that are in their lungs. Children cannot have vests until they're age 2 because vests do not usually fit infants. This little infant-looking baby here probably is not 2 years old, but that's about as small as a vest comes. The vest therapy will be part of their pulmonary toiletry, but it goes hand in hand with the medications that they use. And then the other picture, the girl in the pink vest, would represent probably a teenager who also is using her nebulizer therapy. The respiratory therapists and the physicians work with frequency of the vest therapy and then the settings of the vest to make sure that it's really an effective treatment when they're using it. And the goal is to mobilize those secretions and to get them out of their lungs. So for the pharmacology aspect of the pulmonary system, we use bronchodilators, so albuterol and levalbuterol. These can be used to prevent bronchoconstriction from the other nebulized therapies we're going to ask the patients to do. CF-related asthma really isn't asthma because it's not reversible. It's an irreversible obstruction of the airway, which comes from their thick secretions. For the pulmonary system, we also have mucolytics. So the mucus that's in the CF airway is thick, viscous, dehydrated mucus from extracellular neutrophil DNA. So that is where Dornase alpha came into play. That was created to target this sort of proteinaceous material and help break it down so patients could expectorate it better. The hypertonic saline helps to draw water into the airway to make the secretions thinner so they can actually also cough them out. 7% is also very irritating to the airway, so patients will often say that 7% makes them cough, which is also a goal. Both of these products have been shown to improve pulmonary function and reduce hospitalizations when used correctly. Another area in pulmonary is anti-inflammatory. So we know this is a neutrophil-driven inflammatory process that can, the anti-inflammatory can degrade proteins in the airway, which leads to bronchiectasis and obstructive airway disease over time. So collapse and plugging of the smaller airways. Centers used to use ibuprofen scheduled with therapeutic drug monitoring to prevent this sort of inflammatory process. We've moved away from that more just because of the monitoring that is required. And it was shown to be helpful in the younger children, but the efficacy hasn't been proven in adults. So we do not currently do that here. There could be patients where they would consider it, but it would really be patient specific. But azithromycin has sort of taken that place of ibuprofen. Azithromycin has, we think, inhibition of IL-8 and other cytokines, and it has been shown to improve lung function and reduce exacerbations, whether or not the patient has a chronic infection with Pseudomonas, which we'll talk about in a little bit. So order of therapies is something we spend a lot of time talking about in clinic. The patients need to use the meds in the right order so they can have the best effect. So usually they begin with their bronchodilator, which can be albuterol, levalbuterol, then their mucolytic, their 7% or their Dornase alpha, There's no preferred particular order here, but usually we counsel Dornase before the hypertonic. The vest therapy can be either concurrent with the nebulized treatments or it can be after. And then if they're on inhaled corticosteroids or inhaled antibiotics, those will need to be the last thing that go into the airway. You do not want to cough out the corticosteroid or the inhaled antibiotics if they're taking that. So back to our patient case. During his visit, JL notes that he has greasy stools with oil in the toilet when he goes. So what should be a consideration here? I'm going to call on Tabitha and Corey. Yeah. So he's 27.4 kilos. He takes pancreolipase 12,000 units with meals. So that calculates out to his mealtime dose of about 1,750 units of lipase per meal. So remember, the upper limit is 2,500 units per kilo per meal. So we can add an extra Creon tablet and increase his dose closer to 22 units of lipase per kilo. So you also interview him about the order of his inhaled therapies. He uses his Dornase alpha immediately when he gets home from school, so he doesn't have to do it before bedtime. All the other therapies he does first thing in the morning before school. So what could be problematic with this? We just went over order of inhaled therapies, which, by the way, are also important if they're admitted to the hospital. So that's a consideration too for the hospital pharmacist here. So you review your findings. They're concerned he's having an exacerbation. We've identified that his Pulmozyme is given in the middle of the day. It really needs to be done with his other treatments and his vest. And the pulmonologist says, I really think he's having an exacerbation, but he doesn't have a cough and he doesn't really sound like he has a lot of crackles on exam. But just looking at his FEV1 and his weight plateau, they're concerned. So you convince them that maybe this isn't an exacerbation. And the decision is made to increase the enzymes and do the respiratory therapies in the correct order and see him back. He also gets a routine sputum culture. So this brings us to microorganisms of the Cf airway. So the nice thing about cystic fibrosis is there is a national database of CF patients where data is put in. It's an international database. And you can see what organisms have grown over time and how pulmonary functions have changed with different interventions. So we really have a wealth of data when it comes to what kind of organisms are prevalent in the population. So you can see that from 1993 to 2019, Staph aureus has increased in prevalence from surveillance cultures in clinic. And you do see that Pseudomonas has decreased over time to around 40% of patients. And we'll talk about what some of the reasons could be for that. And then you look at the age of your patient and what are the common organisms. So we see that the Staph aureus kind of peaks early around 6 to 12 years of age and then sort of tapers off as they get older. And then the Pseudomonas usually start to show up around age 10 to 15 and then will peak as the patients get older as well. So Pseudomonas eradication is another big focus for cystic fibrosis patients. Pseudomonas infections lead to more parenchymal damage, more rapid decline in lung function, and an increased mortality. So 2.6-fold increase in 8-year mortality in children with cystic fibrosis once they demonstrate that they have Pseudomonas. So our goal is to postpone these chronic infections for as long as possible. There was an EPIC trial that came out in 2015. This was a long trial that had over 300 CF patients in it in 4 arms. They were trying to determine what is the best way to get rid of Pseudomonas in the airway. So there was 4 arms, inhaled tobramycin plus or minus PO Cipro. And they found that there was no benefit to the addition of Cipro in eradicating Pseudomonas from the airways. And there was no benefit to continuously cycling inhaled tobramycin. So this created our guidelines, which are at first Pseudomonas isolate, give tobramycin 300 milligrams BID for 28 days. And then the patient will follow up for a repeat culture. We have a lot of inhaled antibiotics we use in cystic fibrosis. Tobramycin by far is the most common one. This formulation was created to target Pseudomonas. We now have aztreonam, which some patients like a little better because it is a faster nebulization than the tobramycin. Amikacin is really for M. abscessus patients. And then we have non-commercial products that we've used in clinics, such as vancomycin, Levaquin, and colistin. Your antibiotic dosing in CF, this is relevant to hospital admissions. So our goal is to optimize pharmacokinetics based on these patients' altered values. We know they have an increased volume of distribution. We know they have increased clearance. And so the consequences are really that we need higher doses, particularly of beta-lactam antibiotics, and smaller intervals between doses. So some examples of adult antibiotic dosing in CF that some of you could see, cefepime 2 grams Q6, ceftaz 3 grams Q6, and meropenem 2 grams Q8. Aminoglycosides, we still will even use the 10 mg per kg in older adults, Q24 hours, and we'll do AUC monitoring to make sure that we're meeting the pharmacokinetic goals based on what their last Pseudomonas MIC was. So back to JL. 5 days after his appointment, his sputum cultures show 3+ pan-sensitive Pseudomonas. So you call the patient. He is now using his Dornase alpha correctly, and his stools have improved since we changed his enzyme dose. So what would be the next intervention for JL? Anybody? Yes. So you also review from his last clinic note, his FEV1 was slightly decreased from 91 to 85, but he had no cough and no increased sputum production, which isn't unusual. You don't always have an increased cough or sputum production if you first isolate Pseudomonas. So we're going to begin inhaled tobramycin therapy for a month, and then we'll repeat the sputum culture once that's complete. So now we'll get into the corrective pharmacotherapy. This is an entirely new class of medications that came out since I was in pharmacy school, and I certainly have learned a lot about them being in CF clinic. This is just another cool picture of the CFTR. So back to the mutation classes, a refresher. We have class 1, 2, 3, and 4, the primary classes. The percentage that it occurs in the population is represented there. And this is really talking about just one copy of that particular type of mutation. Again, F508del is the most common mutation that we find, and it's a class 2 mutation. And we'll talk about some of the different therapies and where they were most effective. So modulator therapies sort of fall into 2 subgroups. You have potentiators and correctors. Potentiators will hold the CFTR open at the cell surface, and that is ivacaftor. Correctors will correct the protein folding or misfolding, and then it directs the traffic. So if the CFTR doesn't know where to go, it can help tell it where to go. We have 3 agents in this category: lumacaftor, tezacaftor, and elexacaftor. I lumped all these clinical trials that brought these drugs to market in just one group, just for simplicity. All the trials were 24 weeks long, and their primary endpoint was FEV1 % changes from baseline. So an appropriate endpoint for a population where you really care about their pulmonary function and improving their pulmonary function. Their secondary endpoints were weight gain, quality of life, the respiratory domain score, which is how do you feel today based on how you feel other days as a CF patient, number of exacerbations within the 24 weeks, and then sweat chloride levels, which is a really objective measure. It was pretty interesting in the trials. So ivacaftor, it was the first agent that was approved in 2012. And this affected gating mutations. So that's class 3 mutations where your protein is there, but it just doesn't quite know how to open correctly. And this was a huge trial because the patients who participated in this really compared it to placebo, and they got 10.6 points on their FEV1, which was huge. There was no intervention we had done prior to this date that had really changed the FEV1 of the patients with CF. One of the monitoring parameters that came out of this particular trial when ivacaftor came to market was cataracts, and this was really in animal models. It wasn't observed in other older animals, and there have been some case reports in patients with CF who have glucocorticoid use and radiation exposure. So you'll see it as a common theme for monitoring when we get to how do we monitor all of these modulators. The next modulator was Orkambi, or ivacaftor lumacaftor. It was approved in 2015, and they were really trying to add something to ivacaftor that would help patients with some other mutation types. And really that big group that has 508, 2 copies of 508, so homozygous. They found the patient's FEV1 increased by a mean of 3, which is okay. It's not as exciting as the ivacaftor alone and those gating mutations. But it was an improvement, and it added something for additional patient groups. But greater than 5% of the patients taking Orkambi experienced nausea, fatigue, diarrhea, and rhinorrhea. So this has been called Orkambi flu. In the patients who experienced this really had a lot of complaints about how they felt. And then if they were non-compliant with Orkambi, every time they started Orkambi, they would feel like they had the flu again. It did have a lot of liver effects, and we'll talk about that when we talk about all the monitoring for the modulators. And there's an interaction with contraception for these patients. The next modulator that came to market was Symdeko. So this is ivacaftor again, so the very first compound, but instead of lumacaftor, it's tezacaftor. This was approved in 2018, and it was initially approved for patients who were homozygous for 508. And then recently, in December of 2020, there are a group of heterozygous patients that have 508 and something else that got package labeling expansion. So in the homozygous 508 trial, there was an FEV1 increase by a mean of 4. So again, slightly better, maybe slightly better than Orkambi, but with less side effects. So there was no Orkambi flu with these patients. And then in the heterozygous trials, the ivacaftor versus ivacaftor tezacaftor, there was a difference of 2.1 between the groups. And this drug had no effect on hormonal contraception, and it didn't affect liver enzymes as much as Orkambi did. This is the packaging expansion. So this looks like a whole bunch of alphabet and letters, just to give you an idea of how many different mutations and how specific they are about these therapies and who's approved for them. And then finally, we get to Tricapta, which is the most recent modulator that was approved. This is, again, basically Symdeko, so ivacaftor, tezacaftor, plus the addition of elexacaftor, an additional compound that is also a potentiator. So this was approved in 2019. This was approved for heterozygous 508 patients, which covered almost 92% of all patients with CF. So that was a huge group that were now eligible for modulator therapy. And some of the biggest differences were when they looked at the heterozygous patients who had had no options before for modulators compared to placebo, they had an increase of 13.8. So far above and beyond what anything had shown so far in any of the modulator trials as far as adding to their pulmonary function. When you look at the homozygous patients, those would have been patients that were eligible for Symdeko prior to Tricapta. They compared Symdeko to Tricapta and found that the Tricapta group got even 10 additional points on top of what Symdeko could offer. So it was a huge difference for all of those patients. And one of the common side effects that was noted for women taking hormonal contraceptives was a rash. So that's something that we do counsel women about who may be taking some sort of birth control. The rash, fortunately, you can treat through the rash, and we've had maybe one patient who's experienced that. Okay, modulator comparison. So all the slides I just went through, but really with your modulators listed in the order that they were approved. So ivacaftor at the top, 1 copy of a gating mutation, so that's a class 3 mutation. And you only have to be greater than 4 months of age to take this one. So we have all kinds of formulations that babies can take. The next one, ivacaftor lumacaftor, just for homozygous 508 patients, greater than 2 years of age. and then ivacaftor tezacaftor with the homozygous and then the limited heterozygous 508 greater than 6 years of age, and then ivacaftor tezacaftor, elexacaftor, Tricapta, either heterozygous or homozygous, and you have to be greater than age 12. Monitoring for all of these modulators includes a CMP every 3 months for a year, and then you can do annual. You need to also include bilirubin in that monitoring. Cataracts, so like we talked about with ivacaftor, that very first trial that looked at the animal models, ivacaftor is in all of these modulators, so cataracts and an annual eye exam will be a recommended monitoring. And then for dose adjustments, if you have strong 3A4 inhibitors, you will need to make adjustments to the modulator, and those are all spelled out in the package inserts. And if your liver function tests go 3 to 5 times upper limit of normal, you will have to use a different dosing strategy or interrupt therapy altogether. Ivacaftor, lumacaftor was the biggest offender of this, and lumacaftor is no longer in some of the more, call them advanced compounds or combinations. So I think the extreme liver effects we saw with lumacaftor will probably go away eventually as these other modulators get approved to younger ages. And then if you do have liver impairment, a Child-Pugh class B or higher, then there is adjustments that you need to make. So counseling points, you want to use 12-hour intervals for the modulators. Ivacaftor has to be dosed BID. Some of the other modulators do not. Patients should take their modulator with food. So the AUC is 3 times higher when the patient takes it with food compared to in a fasted state. So usually we counsel a meal that has some fat in it, and then also they need to remember to take their enzymes. The purge is something patients will describe, and that really is thick secretions from their lungs coming up in the first several days to week after they start the modulator therapy. And the thought is you've corrected that CFTR, and now those secretions are much thinner than they ever have been, even with their inhaled therapies. Your morning doses are typically more important than your evening doses. So your evening dose is usually just ivacaftor by itself. So we try to counsel patients appropriately on when to defer, depending on which product they're on. And then the flu-like symptoms, so we talked about Orkambi flu, which occurs with the ivacaftor, lumacaftor more often. So back to our patient case, JL returns to clinic for repeat cultures. He's now 12 years old, and his genotype, just for a reminder, is the F508, and he has a 2184 insertion A. So his FEV1 is improved from his previous visit after inhaled tobramycin, using the right pulmozyme during the right time of day. His weight is up slightly, his height's the same, and his BMI is still in the 5th percentile. His previous cultures had Pseudomonas, but he's here for a follow-up. So we're gonna see what those cultures are today. So what intervention could be added for JL today? He's a heterozygous 508. He's over 12. Yes, Tricapta. Okay, so back to our video that we just watched. He has 1 copy of the 508 mutation. And so his CFTR is probably stuck somewhere in his endoplasmic reticulum, bouncing around, doesn't know where to go. So his 508 is a class 2, and the 2184 is a class 5, but it may not really be relevant because he has at least 1 copy of the 508 here. So he is a heterozygous 508. So you recommend adding Tricapta to JL's therapies. So what labs and counseling should be included before initiation? So we're going to get a complete metabolic panel, and we're going to do an eye exam, or recommend that he get an eye exam. We won't physically be doing it. And then you prescribe ivacaftor, tezacaftor, elexacaftor, 2 tablets in the morning and 1 tablet in the evening. He returns to clinic 3 months later. He reports no cough. He has better energy and appetite. His FEV1 is now 105% predicted. His weight is up significantly. His cultures are pending, but his last one was just mixed respiratory flora. So the Pseudomonas did not show up again in his repeat culture. And now his BMI has increased. So we draw a metabolic panel that's within normal limits. So are his changes in FEV1 consistent with reported benefits from the trials? So yes, he got a 14-point improvement. He's had weight gain, which was a secondary endpoint in the trial, and they looked at absolute BMI change. And usually patients gained 1 point on their BMI. And then he was previously in the 5th percentile for BMI. Now he's in the 15th percentile. So what are the pharmacist roles in CF clinic? This is something that's really been a hot topic in the CF world for the last several years. In 2015, pharmacists were recommended team members to have an accredited CF center. That means that if you are affiliated with the CF Foundation and you are an accredited center, it's recommended that you have access to a pharmacist that is on your team. It's not a required member of the team. So if it was a required member, you couldn't be an accredited center if there was no pharmacist. So in 2015, pharmacists were recommended. We can perform medication histories, the reconciliation. We can find cost-effective therapy for the patients. We're a liaison between inpatient and outpatient transitions, which can happen a lot from clinic. We help with drug dosing, the drug interactions, even more now with the modulators because providers have a lot of questions. We do pharmacokinetic and lab data interpretation if we're monitoring in the hospital. We can optimize the selection and doses of medications. And now that we have an aging population, there's CF and non-CF medication questions that come up. So as we have older patients in clinic, a lot of times they have adult problems. And so the providers who are pediatric pulmonologists may not be as comfortable with your SSRI. We can troubleshoot the pharmacy insurance issues, and we do that in conjunction with our pharmacy technician. Research can be a part of clinic, and patient-focused medication education is a large part of what we do. So we have very small children in clinic all the way up to like 60-year-old adults. So you really have to tailor your medication education to the learner and their family in a lot of situations. And you can assess the sustainability of the regimen. So the regimen we looked at for JL is kind of an average CF medication regimen, but they can have upwards of 20 medications on their profile, especially as they get older. So pharmacy technician roles, they can help verify insurance benefits. They do prior authorizations and formulary reviews. And I would say for us, this has been really important. Where we're located, we have Georgia Medicaid and Tennessee Medicaid patients. And between those, there's 7 managed care organizations that all process information differently. So Brittany, our pharmacy technician, keeps us on the right track with the different insurance companies we have in the most efficient way to get medications covered. She helps them in clinic with assistance programs. So instead of telling the patient, oh, go enroll in this program, she actually does it for them while they're in clinic. Coordinate medication refills if needed, can help families with access to medications. Sometimes this is just cohorting all their medicines to one pharmacy, if that's possible. And participate in QI initiatives. So we are currently looking at how long it takes us to get a prior approval with a pharmacy technician versus pre-pharmacy technician. So the impact of pharmacist and the technician will be published. There's going to be some data published this month or last month in Peds Pulmonology. They've been demonstrated to improve access. They increase objective measures, so body weight and BMI. We assume this is because of increased access to medicines. Reduce prior authorization times, reduce medication delivery times, expedite refill authorization, reduce the number of pharmacies used, and collaborate with a respiratory therapist. That VEST therapy is as important as the pharmacotherapy that goes along with it. So really talking with the RTs and helping come up with a plan that works for the patient. And then it augments the team-based approach and discussion of therapies for the patient. So in summary, CF is a complex disease that affects many organ systems. The supportive pharmacotherapy is imperative to overall health. The corrective pharmacotherapy, the potentiators and correctors, presents new monitoring challenges, but also improves the objective markers of lung health, so the FEV1. And then the pharmacists and pharmacy technicians have demonstrated and are continuing to demonstrate improvements in quality of care. And this is your CE code. And does anybody have any questions? I did forget to mention how much the modulators cost. It doesn't matter which modulator you are on, it's $310,000 a year. So that's without insurance, but it's all one drug company and they have an assistance program. So even if patients don't have insurance, a lot of times they're able to get their modulator for like $15 a month. Yeah. Does anybody have any questions? The microphones work in the middle of the room if someone wanted to be brave enough. Yes. Okay. So your formulary on the adult side is ZenPep, or which one is it? Does anybody know? Okay, ZenPep. So what we usually tell our CF patients to do is bring their Creon. Creon's our preferred agent in clinic. We do have some patients who've switched to other enzymes after maybe they have failed Creon, but by and large, that's the one that we use. We also stock it in children's for our CF patients. That's our formulary. So you could always get it from us if you guys had a CF patient that didn't have their Creon with them. So that's an option as well. As far as interchanging them, I haven't really looked at that because it's not recommended. And I think most patients are very particular about their enzymes. I have heard recently that the Creon pricing and the ZenPep pricing are very similar. And I don't know what the advantage is to ZenPep in adults over Creon. Hmm. So some patients, ultimately patients should end up on both if they can tolerate it. So we have some patients who say, I cough too much or I cough up blood when I do the 7% because it's so irritating. So we have patients that will self-titrate their 7% based on how much hemoptysis they've had that day or that week. Usually we start with Pulmozyme, especially for the smaller children, because it's a little bit easier to tolerate. And we sort of layer it on in a stepwise fashion as they get older and their bronchiectasis usually gets worse. Okay. Thank you.